Okay, Tony, I'll catch up with you later. Bye.
Okay, take care, Habib.
So welcome you again to our education series in Hamad Medical Corporation. So moderator will be myself and Dr. Bako, and today's speaker, Dr. Tony Tannoury, will speak about his experience about MIS spine surgery. Dr. Tony Tannoury, he finished his medical school from Lebanon, then he finished training orthopedics and spine in the US, and he's a co-founder and president of International Musculoskeletal Society. He is well known internationally for developing MIS techniques and implant, which we use it every day. Welcome, Dr. Tannoury. Could you please share your screen?
Thank you very much, everyone. I'm very honored to be among you again. Hamad Medical and the Doha, and of course, the friends of the Doha group are all friends of mine, and I wish everyone happy and healthy finish of 2020. So let me share. I already shared screen with you. 1 second. So the when we talked.
Dr. Tony,
Naam.
I cannot see your screen, so we see only your video.
I thought. Okay, so I thought I did share. Okay, 1 second.
Can you try now?
Log out 1 second. Let me log out of these. Give me 1 split second. Share screen. Share. Okay. Do you have it now?
Yeah, we can see your desktop now. Yeah, we can see the presentation. Thank you.
Perfect. So when Dr. Abdul-Jabbar and we talked about what I can potentially be talking about, I said, maybe we can discuss my difficulties and my practice over the last 15, 16 years in MIS. What I did find useful and I kept it, and what I find more difficult and useless, because as we all know, and I'm very glad that you guys do a lot of MIS. So, a lot of techniques and technologies come and go. We all try, dabble with it, tried it, practice with it, few cases. And then after that, we find that it doesn't make sense or it's not worth it. And then we revert back to a different technique. So I can speak from 15 or 16 years of experience in that space. It's not formal, so feel free to stop me if any question, if anything that you didn't grasp very well or you don't agree with, we'll be happy to discuss it from my perspective. This is my email. This is my email. Feel free to use it if you have any follow-up questions after the lectures. As Abdul-Jabbar mentioned, I am the developer of the Viper minimally invasive system and also the lateral cage for the Pew. So everything I said is also biased in that regard. As we know, in the spine community, we usually do have the vast majority of the spine indications are either for neurological decompression, spinal fusion, stabilization, or deformity correction. And deformity, as we all know it, is usually in the 3 planes. So the minimally invasive surgery, we all know the potential and theoretical benefit of it. Let me see 1 second. Okay. So, however, every time we're trying to dabble with a new technology, and MIS is the same way. The question is it safe? Is it effective? So yes, you could do a safe surgery, but it may not be able or effective to produce and to achieve what you want to achieve. And also, if it can be done, can you do it for a large percentage of your practice? And as we know, this is our small, could be a one disc disease, but also could be a complex pathology, either tumors, infections, deformity, fractures, and so on. And also we have to calculate, what is the value proposition? Are we going to be paying a lot for it? So over the last 15 years, we realized, and I'm sure you do the same in your practice, that's why I guess going to skip through that quickly, that it's a great option for trauma. Instead of you opening the spine, the muscles, and so on and so forth, you can correct a fracture. You can percutaneously stabilize any fracture, and then we don't even have to do fusion. And this is a patient, early on from, about 15 years ago, I did this patient. She did have a L4 burst and L3 compression. She's a daughter of one of the physicians with us. So we did the percutaneous stabilization, and we took the hardware out at 4 months after the fracture healed. And she still now has, very, very good results from it. This is another patient. She's 22. She's a teacher and a model. She did have what we call a chance injury, which is bony chance on one side and soft tissue chance on the other side. So we all know bony chance could be treated very well in extension and brace. Soft tissue chance, you need a fusion. How about if you have a mix of both? One side is a bony chance, one side soft tissue. So fusion may be too much, and bracing may be too little. So the MIS will be a good option for this. You can see that on the left side here, there we put 3 screws because this is the soft tissue side. On the right side of the screen, you see the fracture has reduced when we, reduce her back percutaneously. And this is the patient right there. And now, after 4 months, we did CT scan. It shows, on the left side, you can see the bony healed. And now we take the hardware out. The patient left with no fusion. This is a patient here with subtrochanteric fracture, but at the same time, they have L5 burst. We all know that the lower lumbar fractures they tolerate very well non-operative treatment. This patient would have been treated with a brace with no surgery in my practice. But the problem is with the subtrochanteric fracture, the patient cannot have a thigh brace on and so on. So it makes the recovery quite difficult. So MIS will be a nice part of the multi-injured system, multi-system injury concept, basically fixing everything at the same time. And so this is a patient here. We did the percutaneous stabilization on the patient. The hip was fixed, obviously. And then here we took the hardware out later on with no fusion. If you look at the vertebra, when you do stabilize and do lordosis, actually you gain length in the front because the bone wants to try to grow back. And on about 18% of our patients, we looked at, they actually bridge and they autofuse one level on the fracture site. This different patient here with the vertical shear type pelvic injury. You can see the left hemipelvis is up. So my partner, Dr. Tannoury, had to fix that. And the MIS was a great tool to create the delta concept, for these, or neutralization device with iliolumbar support. So this is the patient here. That's me and Paul Tannoury, who did the pelvis, and I did the lumbar spine. This is patient with the L1 compression with severe angulation and vertebral height loss. We saw the patient 6 weeks after because he was being treated elsewhere, and he was brought to us for a second opinion. So this one we could not save with no fusion, so we had to fuse. So we did minimally invasive lateral corpectomy and percutaneous stabilization, for this patient right there. So the bottom line is that we found that MIS is a great option for trauma, and also even better option and when you're not trying to fuse the spine, because you spare the muscles, which are the engine of the car. Now, moving into degenerative conditions, we can see here we have L4-5 spondylolisthesis, and some disc bulge, some degenerative disease 5-1. Of course, you could do this, case in so many different ways. You could do simple posterolateral fusion, open or MIS. You could do, TLIF, BLIF, XLIF. You could do any procedure, and usually the results are fairly good. This patient, got the two-level TLIFs with a good result. So there's plenty of papers on the validity and the efficacy and safety of the MIS in the one-level, two-level pathologies, which shows at least as equal or superior to the open surgeries. So I'm gonna skip through that. Now it becomes, this is a patient of mine, and you can see that she does have a 3-level disease, L3-4, 4-5-5-1, bone on bone with spondylolisthesis, vacuum disc 5-1, and there's some early degenerative scoliosis happening on the side. So this is early on in my experience. That's about 13 years ago, shortly after I joined the BMC. And we did a lateral fusion on the L3-4-4-5. And I thought that, doing a posterolateral fusion percutaneously from the back at L5-S1, and that's what we did. So the patient was actually very happy the first post-operative period, but when I'm looking at her, I immediately kind of realized that it's not what I wanted to do for her. I wanted to do a better job basically for her. This patient here 1 year later, she's still, better than before the surgery, but she's still sagittally imbalanced, and you can see why. Because of the L5, we did not address the sagittal balance. We did not address L5-S1, which is a very useful disc, and we did not take advantage of such a great place to build lordosis and so on. This is another patient with HIV and hepatitis C, very soft bone. And we all read about in the literature about unilateral fixation in cages and so on. And we tried to do that, and obviously it did fail at the fracture, at the pathology side, but also below it and above it. This is patient came to me with the degenerative scoliosis. Again, this is about 12 years ago, early on my experience. We all know that this is diffuse disease. The treatment is multi-level fusion, and this is what we did: multi-level front back. But I'm not, if you look at it, it's not that great correction of the sagittal balance. It's not something that I would be proud of today. So I wanted to bring this up, what we have struggled with along the years in developing the MIS concepts and treatment options. Also, the MIS, beside the typical risks that you guys, we see, misplaced screws, nerve injuries, sagittal imbalance, screws pulled out and misplaced and so on. But it seems like also MIS has an added risk, which is it could be rhabdo. And the rhabdo is basically when you try to pass the rod, and particularly for these multi-level surgeries, fusions, and if your rod is done deep enough under the muscle and you try to force a rod on the screw heads, you squeeze a lot of muscles there, and you can create rhabdomyolysis. And I've seen 2 in our hospitals, but they do recover, and they did, it takes them about 3 to 4 weeks for the kidneys to clear them out. And this is study here by Uribe also that show 5 cases of rhabdomyolysis. So, but after all this introduction, is it worth it? So here's how I think of it. And I'm sure the older you are on this call, the older you are, the more you agree with me that, you know, if MIS is good for 1 or 2 level pathology, it should be ideal for much more complex. If it's not, then it's not worth it. Because if you do a study today, you say which TLIF better results? Is it MIS TLIF or open TLIF? You're gonna find very little difference. And actually you may find maybe, you know, one certain technique may be a little safer than others. It could be open, it depends on your experience. But you're not gonna notice a significant difference. But where you notice significant difference in the results and the outcome should be in the more complex pathology and the 70 and 80-year-old, you know, patient who cannot tolerate open surgery. And the patients who had multi-level fusions where you had the choice between big open surgery and MIS. Of course, provided that you can deliver and then produce good results. So tumors, deformity, trauma, patients with significant comorbidities. So for me to learn a technique and practice it and then invest so much time in it and energy, for me to practice on 1 level or 2 level disease, it's not worth it for me. So I have to be able to apply it to more complex pathology. And because, you know, in my practice, I have a lot of that complex pathology. I like to take a couple minutes to, particularly for the young doctors here on the call, to share with you my learning curve. And when I say learning curve, it's not in years, it's actually in levels. So if you look here, say, if 1 level pathology, 2 level pathology, 3 level pathology, 4, 6, 6 plus, etc. If we do open surgery, think of it as a resident now, and then the resident become a fellow, and then the fellow you go and you start your practice. Of course, you know, you're comfortable doing 1 level or 2 level disease and so on, and then you start practicing, and then 2 years later you're more confident, you're faster, you're less blood loss, you know, you're more accurate, you know, etc., more organized. So now you start tackling 3 or 4 level or more, you know, efficiently and so on. So with time, your learning curve is getting better and better for more and more levels. But with MIS, at least the way I see it, you know, with a lot of surgeons who come to see me to see how we do minimally invasive, this is the curve in the yellow line. You work hard on MIS TLIF 1 level, and then eventually start getting a little better results than the open surgery, and then you have a patient with 2 level disease, and then your results sink a little bit under the open surgery because now you're doing the 2nd level, taking time. Maybe you get more dural tears, more pseudoarthrosis, you know, because you're tired, but you learn how to overcome that, and then you become faster at it. And then when you become faster at it, then 2 level you become efficient with it, and then your results peak. It gets a little better than the open surgery. As you notice that it's a little better, not a lot better, because as we said, for 1 or 2 level disease, the clinical results are not that, the delta is not that great. But you go to the 3 levels, and in my mind, 3 levels is the watershed area, the point. It's like a bifurcation on your highway. You know, either you go right or left. And I find that most MIS surgeons, either they excel at 3 level and up, or they dive down. And these are the reasons why. And I sat down one day, I say, I want to write down what are the reasons, beyond that. Basically, how to address L5S1. As you saw from my example, that I did not take advantage of the very valuable disc called L5S1. How to achieve fusions in multiple levels. How to do the iliac fixations. You know, if you're doing multi-level disease, that means you're gonna, more often than not, you're gonna be needing iliac fixations, you know, as to sacral Eller screws and so on. Deformity correction. Are we able to correct the spine in sagittal, coronal, or axial plane? And those become very, very difficult, you know, after 3-level disease, because you cannot do 3-level MIS TLIF. You cannot do level 3. Yes, you can, but you get tired. You produce less good results. You get more, more dural tears and more pseudoarthrosis because you're not doing the good job that you would do. Remember that MIS, adding one level, you're almost doubling your case. Open surgery, adding one level, you're adding a little bit to the procedure. That's why past certain multiple levels, open surgery has more sense. But, so here's my experience. This is the first case I show you. There's nothing in 5S1. And I start adding later on and do lateral from the side at L3445, and then you do TLIF at L5S1. Still a lot of work because you're doing the lateral from the disc above, and then you're doing percutaneous, and then doing MIS TLIF. And now that's what I do. I do basically all ATP anterior to the psoas approach, and it allows me to go from T12 to S1, including L5S1. In my entire career, we only skipped one patients, which I felt that, it was too difficult for me to do L5S1 because of the configuration of the vessels. Every other patient we were able to do 5-1 when it was indicated, which was indicated in 62% of the cases in our study we published. So these are the challenging, the 3 challenges we face, sagittal balance correction, fusion, and decompression. So if you look here, how can we achieve sagittal balance? You do achieve sagittal balance either by doing osteotomies, whether being SPO, PSO, VCRs, any kind of osteotomy that you like or read about, or you can do some sort of interbody reconstruction. Fusion. Now, if you're doing MIS, it's very hard to do multi-level osteotomies or a real osteotomy, because if you do a little facetectomy, closing down the level, it's easy. But for you to do really take somebody who is a sagittal balance of a positive 23 or 24, and taking it back to normal, that means you have to do a lot of laminectomy above and below. You have to close down the spine so much, and that's not MIS anymore. And the same thing with the fusion. I don't believe MIS surgeons who come and tell me, and I'm MIS surgeon, so I don't believe I'm a surgeon who come and tell me, yeah, I can do T12 to S1 or whatever, or L2 to S1 even, percutaneously through the incisions. I go with the burr or the cortical facets. That's either the patient, the doctor is lying to himself or herself, or lying to the patient. Because you cannot do a very successful, reliable fusion every time percutaneously through these small incisions. So the next option you have, interbody fusion. Yes, you can do multi-level TLIFs or PLIFs or whatever, but it's very daunting and very tiresome. And the decompression, the same thing. Either you believe in the direct decompression laminectomy like our open surgeon colleagues, or the indirect decompression and basically opening the space up indirectly. And that again relies on the interbody space. So if you notice, the reason I took some time to show you this slide is to show you that if you want to do MIS, everything leads you to the interbody space, for sagittal balance correction, for fusion, and for the indirect decompression. If you don't utilize that interbody space effectively, that means you cannot do MIS surgery to the maximum extent. So this is a patient who has 4-level disease, to L2 to S1, spondylolisthesis, hypertrophy of the facets, and so on. That's an example of that. Are you going to go and do facetectomy, laminectomy at every level, or are you going to rely on indirect decompression? Are you going to do, fusion? And this is, we all know with the, Wolfgang Rauschning studies, phenomenal pictures. You could see how basically the buckling of the ligamentum flavum, hypertrophy of the, and then disc ossified complex, and what does that work, and so on. Basically, this is the foramen with the patient with the flexion extension. You can see with the extension how the nerve root is being pinched and by the facets, which moves forward when the vertebra above moves backward. So if we want to achieve something like that, when we open the foramen, open disc space, create lumbar lordosis, this is what we we would aim for in any surgery, open or MIS. So these are so to do such a surgery like this one, this is one of my cases, MIS. What are the challenges? The challenges are obviously how to align my screws, how to pass the rods, how to anchor to the pelvis, how to do the pelvic fixation, how to do the derotation, and so on, and how, of course, to manage complications. Something goes wrong in the middle of the case or after surgery, how to manage that. And then, this is part of the learning curve. And this is a guy here, in the, very familiar to you guys. He will tell you that this is the first thing he laid hand on those patients. Our patients, the first thing is the fellow will learn is to drop screws from all the way from T1 to the pelvis. And that's not a very challenging task, of course, especially for Omar. So this is what it is. And then over time, this is how I started in 2005. I used to instrument every level, a lot of screw extensions, a lot of metal, and that comes and work actually against you. It's too little space and for you to work around, but also if you want to do correction of deformity, it's very difficult with all that hardware. This is the same patient 10 years later. So I skip levels, and you can see this is a T10, T12, L2, L4, S1, and iliac. So the one as this one, but in a different strategy that I use over time. And I noticed over time that it's much faster, it's less invasive, of course, because I'm making less cuts and less muscle damage, so on, less passage around the nerves and the vessels and so on, so less risks I'm taking. But also I can do more correction because now I have room and I can manipulate these extensions far better than I can manipulate the vertebra above. That's one advantage. The other advantage of skipping levels is this. Look here, the screw, which is in L4. And let's say I want to pretend that the rod is too shallow or the screw is too deep at L4. If I'm instrumenting every level, the rod automatically becomes very stiff. And if the rod is very stiff, it's very hard to reduce down to the screw. And one of the few things is going to happen. Either the screw extension pops out when you're trying to reduce it, or the screw will pull out, or you're going to struggle and struggle and struggle. So when you skip levels, if you look at this image on the right here, you can see this is a L4, this is L2, and this is T12. Look how much room. So if that screw L2, for instance, if it's too deep, the rod will bend down. It's a still flexible rod, not like a peak flexible, but no, the rod has more distance to bend and adapt to the screw. So in other words, I would have larger margin of errors. So I can have not very perfect position on the screws in terms of height or medial lateral, and I still can get the rods and so on. Iliac fixations, we all know the value. I'm not going to spend too much time on it. It's very valuable for your deformity corrections. This is from Nate Lubal study, which does offload the S1 screws. How to do this, basically, it is so small incisions, basically, it's at the level of the L5, S1. Similar to, think of it, because people ask me what's the best place to put the incision. It's the same exact spot you do for L5, S1 TLIF. And then you go down, feel the iliac crest, and then go down percutaneously. I don't use a wire, and this is only to show you the image. So I go down with the gear shift, and then after that, put the screws in. And then I put the wire to put the screws on top of that. So this is a video here. I think this is me and Omar, I believe. So we're doing on both sides, basically advancing the screws on both sides. And this is the screws here. After I'm done, I disconnect everything, and then now the screw is lodged in the pelvis. Now passing the rod, and you can see when I have the screw, I skip levels. You see how easy now to be able to manipulate and move my hands between the screw extensions. It's a lot easier. but also the rod is more flexible when I'm trying to reduce it to the screw heads. So this is real time. You can see now I'm feeding the next screw up. And this is going up to L2. And here, so always you're gonna find that the difficulty going from the lumbar lordosis into the thoracic kyphosis, that's what you kind of need to struggle a little bit to lift the rod up, to clear the rod. So now I'm all in, so I push it in, and now we start reducing one by one and all of them. So this is the different ways how to do the fusion. Of course, the fusion, the best environment to do the fusion is anteriorly, and the problem is that you have a lot of structure in the way. That's why people drifted to go into lateral and transpsoas approach, XLIF. This is a case who came to me, and this basically summarizes all the complications of a lateral cage. If I'm looking at this case here, and I want to guess what happened during this case. So the surgeons tried to put the cages laterally. He broke she broke the end plates. You could see the vertebrae are here, and it did not correct fascial balance, and then did not address L5S1. So when the surgeon went posteriorly, and this is all my analysis and dissection of the case, how it went. When the surgeon went posteriorly, they tried to create lordosis. So they bend the rod, overbend the rod, and try to correct. Look what happened. He pulled the screws at the bottom, and he pulled the screws up top. He has no fixation, or she has no fixation at the L5S1. So these are the problem with the using. I'm not suggesting that they would happen with every case, but this is a very frequent occurrence in these cases when we don't do enough release in the front and we don't protect the end plate and so on. So this is a patient right there. So that was how it goes. So my approach I would like to talk about is the ATP, anterior to the psoas approach. So I go about 20, 30 degrees, depending on each case. Yesterday, I was doing a case with the severe stenosis in the canal and a lot of disc ossified. So I made my incision more anteriorly, so that way I can enter both sides of the canal from the front and do dissection and do the decompression. So the angle can change from 20 to 40 degrees, basically, depending on the need. If you do have, for instance, a burst fracture and the big fragment in the canal, I will make my incision slightly more anterior, so that way I can access the canal much easier, and so on. This approach will allow me to do T12 to S1 in one single incision, and obviously muscle splitting, psoas sparing. These are different incisions you can do for different pathologies. This is a patient. Here, this is the psoas muscles. You can see here, I can fall right in front of that psoas muscles on the front. Here, I'm exposing L45, L5S1. On this L45 disc, L5S1. This is the psoas behind me, and the vessels are behind me here. And you can see I'm barely touching the psoas. I'm not even retracting on that psoas muscle. People ask, can you access the canal? Of course, look at the Penfield 4, in the canal here from the front. I can access the canal. I can do decompression in the front simply because of my angle, how I approach it. Oops, this is a video we're supposed to do. This is showing you the dura and the nerves and the decompressed. So for the indirect decompression to work, we have to reestablish a disc height. We need to create a vacuum around the cage. In other words, when you put the cage, when you spread the disc and put the cage, the surrounding remaining disc or ligamentum flab, or not ligamentum flab, on the annulus, They have to buckle in, not out. And I'll show you what do I mean by that. And you need to reduce the anterior and posterior translation, of course, by stabilizing the spine and stop the micromotion. So this is some schematic that I do for what's the difference between lateral and anterolateral approach. The anterolateral approach is not, and I said it's not a lateral approach through slightly more anteriorly. People tell me, oh yeah, this is XLIF, but slightly more anterior. No, it's not XLIF, it's not direct lateral. And remember, I designed the lateral system for DePuy, and I make royalty every time a surgeon uses the lateral system for DePuy. But I never use it in that capacity, in that function. So I'm speaking against my own benefit, financial benefit, simply for the reason, for the following reasons. If this is the psoas muscle here, this is the disc, and you go in down and split the muscles, and here you work through this, and you do what I call a middle third discectomy. So you go in, you try to take the disc out. Of course, you're afraid to go posteriorly because you have the nerves. You are afraid to go anteriorly because you have the vessels. So you're always very careful of doing a little too much. So you're leaving, and you leave a lot of the annulus and the disc in there. So when you put in the cage in, look what happened. The cage, because you have so much remaining soft tissue, and you push some, even narrow the foramen even further. And we all seen these cages when they go in, and then the surgeon tell you 2 days later, 3 days later, they see the cage back into the inside the psoas. And the reason, because they did not take enough disc soft tissue. So now it works as whoop stresses basically, and push the cage back out, just like a baby coming out of the. So this is the ATP. The ATP, you go from the front. So look, you have much bigger access to the disc space, and we clean basically 95% of the disc. I could see it directly. I can take 95% of it out. There'll be only remaining that little wafer here and then here, which I can rip indirectly by simply distracting on the end plates, because now it's so little left. So now when you put the cage in, look how much space you have between the cage and the remaining disc. And that would create the vacuum that I talked about before. So when you put the disc in and the disc, you're distracting the vertebra, now the disc, actually remaining disc will shrink, will go out. This is what, the indirect decompression we talk about. So
يا بالحن
go ahead.
والله في الغرفة. الو ايوه.
Oh, okay. So these are the indirect decompression. This is the cases here. Now, how about some surgeon, they say they go from the side, but they go in front of the psoas. And I'm sure you heard that before from different surgeons. Yeah, I go through the side, from the side, but I retract the psoas posteriorly. Basically, you're getting the worst out of the two cases. So basically, you're retracting on the psoas and all the nerves inside it, but also you're not able to take so much of the posterior disc. And now the cage, you may injure the vessels in the front, so on. So really, I do not recommend that. And some surgeons, a lot of surgeons tell you, oh, I do it, I go from the side, but I retract posteriorly. So it doesn't change much what we talked about. How about mechanically? Mechanically is a different procedure as well. So think of it as this is a vertebra here. Think of it as this is L3 and this is L4. These are the ALL. This is the PLL and the annulus. And these are the facet joints here. And this is the canal here, for instance. So when we start distracting the L3-4, this is the first trial you use, or whatever distraction that you use. And yes, you stretch the ALL because that was kyphotic or flat disc. You start stretching that. Look, the posterior and the middle here, or the posterior annulus are still lax. Now, once that start getting tight and you're distracting more, what's going to happen? That anterior tether is going to be firm. Now you're going to start distracting posteriorly. So the next distraction up, and I want you to look at your MRI, at your imaging on the fluoroscopy between the first and second and third dilators that you put in. you're gonna see that the first dilator you create lordosis, the second and third you start losing the lordosis, and eventually you wanna, as a surgeon, you wanna create more lordosis and you put a larger cage. Now you start violating the end plates, and now you create a fracture of the end plates because you try to force the vertebrae to spread. So what the ATP is different, anterior to the psoas is different. So this is the exact same model that I used before. I start distracting, with the cage, or not the cage, the spreader. And now this, as soon as this gets tight and tension, I go and release it. I release this one. And once you release it, now you start opening it more, and you can easily rip that one simply because this is less strong. Remember, the ALL is the strongest structure. And now it looks like a fish mouth. It's opening the fish mouth. Whereas the fulcrum of the fish mouth is actually in the back, in the facet. The facet becomes your fulcrum of the correction of the deformity, and not the disc space, okay? So now I can go higher and higher, on the cage, and get more lordosis if I want to, with the size of the cages. My typical cages I use, it's 16 millimeters at L5S1, 16 at 2.45, 16 at 3.4, and I start thinning down to match the normal levels. And look here, like what we're talking about, these triangular discs, that once you're done, you see that that means I've ripped the interior ALL at every level with these. And this is what I call the interior tether. This is the ALL on a young patient, and this is the elderly patients. And young patients, extremely, extremely difficult to shred that without cutting it. So if you were to go transpsoas, it's very difficult. And the elderly person, it's easier to rip this one, but the problem is that the bone itself is weaker. So when you start leaning on the bone and spreading on the bone to rip it, then it's difficult. So for the young patient, it's difficult. For the elderly patient, it's difficult. The only two patients I find that you can go in basically transpsoas and open the disc up and rip this tissue structure out are the two patients one patient had a dish because that structure is brittle, or the vacuum disc. If you have somebody with a lot of vacuum disc and gas in the disc and the end plate are sclerosed, the end plate are strong and the ligamentum is brittle, then you can rip it open. So that's are the two patients where I say, yes, transpsoas patients, doctors can do correction of deformity in these two patients. So this is the same patients here. You can see that I'm cutting the ALL. This is the posterior, this is anteriorly, and now I spread it open. The videos is not working. And here, again, you hear big pop. You hear pop, then this spine is released. And now all of a sudden, instead of having the tether here at the ALL, basically the fulcrum becomes the facet in the back, and you open the spine. This is a patient here, with multi-level disease, spondylolisthesis, and so on, dish, and the vacuum, and you can see how much correction you can get, out of this patient by putting this fixation. And this is a patient right there. So this is a patient here. You can see these are some clinical cases, L4-5 and spondy, grade 1, 2, with some DDD L5S1. And you can do, and you notice in every case that you're able to address the L5S1 properly with enough lordosis and enough correction. This is a patient with scoliosis. You could see that it was corrected nicely on the side, and it is full correction on the AP. This patient had a prior laminectomy in the back here from L1 to S1. And he's got this, a lot of these thick ossified in the front, a very stiff spine. So we went from the front, we did the exact same procedure with the release in the front. And here you can see that we did the cages in the front, and we use them as a fulcrum, and we go posteriorly the same with technique. So look at here. That's why I talked the fish mouth opening and the correction of the deformity, and you're able to correct. Look at the patient clinically standing comfortably with this deformity. This is a patient also has scoliosis, idiopathic scoli, and this is how we do derotation. So we're going to take you through the derotation, either segmentally, you take one level at a time, or you can have a in-block rotation. But also the third one is way by indirect bend of the rod or uneven bend of the rod. One rod you bend more, one rod you bend less, and that will bring the spine together to you. So I use the three techniques in every patient because by uneven bend of the rod, it will bring maybe half of the correction, and I do the segmental derotation and the rest of the correction. So this is a patient that I show you, the 51-year-old cab driver, and then we did the front, released everything from the front, and then we go from the back. The patient had a transition anatomy here. We did not need to do a 5-1 because you could see the as transition anatomy right there. And this is a patient, and look here at the amount of the derotation. So we're able to fully derotate the spine. Spine's processed perfectly in the middle, and good lordosis and good sacral balance. This is actually the mother of my secretary, and you could see the stiff thoracolumbar kyphosis with the degenerative scoliosis. And this is a patient right there, you know, a lot of stenosis. And look, you know, after when you release the front, and then you put the cages, and then you go posteriorly and derotate the spine, you're able to derotate the spine perfectly. Look at the spine's process right in the middle, right there. So you're able to achieve the yoke deformity correction on all three planes. This is the patient right there. A different patient now. This is a different patient. He's a therapist, you know, the respiratory therapist in the hospital, and very similar pathology. And you could see here, except the opposite direction. And look at these spine processes, which are perfectly in the middle, you know, with the good lordosis. And look at the triangular discs that were on a place. This is a patient right there. So revision surgeries, you know, can we do it for revision surgery? Of course. This is a patient actually came from the Gulf region, and this is probably familiar to some of you. And the patient had a prior surgery, and it's broke through, and then there was some question mark infection. So what we did, you know, we took the patient, and the patient had, you know, pseudarthrosis, multiple levels, but also it has a proximal junction disease. So we did the analysis, you know, about the numbers and workup, CT scan, and so on. And this is the MRI on the patient, ESR, CRP. So I'm gonna go quickly. So while the patient on her side, we went and I look at I do small one incision, about 1 centimeter incision in the back, loosen up all these screws. Look at the set screws are loose here. So I release the rod in the back. Now I have a similar to what to quote version back, like basically the rods are released. There's no set screws. And now I do my correction from the side. And when I do the correction from the side, you know, on the next day I do stage 2. Because this is too much, about 3.5 hours in the front, and then about 3 hours in the back. So I do them 2 different days, Monday, Tuesday. And the next day I go in, take the old screws and the set screws out through small incisions, you know, and then we extend the fusion out. So this is a patient before and after in the middle. This is patient also had a prior fusion done in Germany. She went actually for this deformity, but they fixed only the L5S1, which was already transition anatomy. And the patient came to me with this. You know, basically she has a lot of osteophytes, as you see, ankylosis and so on. So when we went from the side, we did anterior osteotomies. You could see here how we osteomize the spine. And then we opened that concavity. We opened that tether. Basically, we detethered the spine. And then we went like this, and then we fixed the back. This back patient, I was looking for its X-ray. I couldn't find them. The patient needed a extension of the fusion proximally. We did that. The patient ended up also having proximal infection, and we extended that as well. So probably that story sounds familiar to some of you. This is another patient here who came from Lebanon. They did L3 to S1 fusion, and basically the CT scan shows 0 fusion, whether posteriorly or, of course, there's no fusion anteriorly. but also has a severe stenosis at the disc above. You could see here the CT myelogram because eventually he ended up needing a pacemaker. So the complete cutoff of the dye at the L23. So while we were doing the L23, because the patient had a pseudoarthrosis at every level, so CT scan here, you know, if I want to run it, then it'll show that the patient has no fusion. Here we go. So for the time constraint, we keep moving. So this is a patient right there. So what we did is anterior decompression, you know, as you see the Woodson in the front at L23. And then we cleared this completely. And then we did the new level, but also we revised the posterior level simply by putting the cages. We left the hardware in simply because, you know, we don't need to take it out. You know, we were able to do the fusion. So this is another patient actually came from Lebanon who had a L3 to S1, L3 to L5 fusion. She had adjacent segment disease, vacuum disc, degenerative scoliosis, and pseudoarthrosis. Again, I'll move a little quicker. The exact same technique. The patient on her side, we release the screws in the back while the patient on her side. And I do my anterior stage, you know, here. So I do my anterior stage. This is the end of the case on the side. We're able to achieve lordosis. Now the posteriorly she's loose. So instead of doing posteriorly, anteriorly, and then anteriorly, and then posterior, then basically we did the posterior and anterior in one stage. This is a patient here between on the second stage. And this is a patient 5 years later. She's developing some proximal junction kyphosis. And 2 years ago, I heard that she passed from heart attack because her daughter sent me a message that her mom passed from heart attack, unfortunately. So lesson learned in this, yes, you know, it's, so we started a little, can I, how much, do I have 5 minutes, 10 minutes, 5 minutes, Dr. Jabbar?
Yes, Dr. Tannoury, we have like 5 minutes, so we'll give some time for the questions.
Perfect, perfect. So the more I did MIS, the more I realized that MIS is not, and I put in capital letters, is not necessarily the open surgery through small incision. It's that sometimes you do completely different procedure than open surgery. I'll give you some examples. This patient had a tuberculosis. You know, I'm at L23. Of course, you can treat that different ways, you know, antibiotics, you know, and all. And when that failed, the patient had lost a lot of weight. It failed chemotherapy, chemo treatment. And look at the, you know, here, the abscess. So basically the patient now requiring surgery. You could do, you know, corpectomy, you could do fusion one level, you could do fusion above and below to get more fixations. But the MIS truly offer you a different perspective. Basically, you know, we did through the side, you know, the debridement of the infection and the fusion of the same level, but we put percutaneously posteriorly as a bracing posteriorly. So we did not fuse the disc above, we did not fuse the disc below. She's 25, I want to save her 3-level fusion. So we fuse only one segment. Of course, I could have put screws here and here, but I would be taking risk putting screws in a weak and infected vertebra. So that potentially could be a problem. So I did not want to take that risk. That's the advantage of MIS because it allows you basically to strategize and to cut your risks to a minimum possible. This is patient here 4 months later. It's perfectly healed. You can see the bone healing. And then now we took the hardware out and this is a fusion, only fuse one segment and we spare the patient 2 additional levels. This is a patient 66. She has severe COPD on home oxygen for the rest of all her life with a lot of steroids throughout her life. And you can see here, she has almost every vertebra in her back is fractured and she had multiple vertebroplasties and kyphoplasties and so on. And you can see here on the CT scan how every vertebra is affected. This patient couldn't sit up because of the pain. So we discussed with her and her 2 sons. I told them, you know, what I have is non-conventional treatment. Basically put what I call infix. Infix is basically a internal support, putting screws and the rods as you see here. And this is what we did. You know, we did put the rods and put the cement And basically, we did very limited fusion, basically. And I'm not saying that we'll get a solid fusion. I took the burr and slightly burr as much as I can from the facets. And I know that I'm not getting very solid fusion. So my goal is basically to load share the rod and stiffen the spine. And this is patient here 2 weeks later, and she was about 4 months unable to even sit. And you can see her home oxygen with one of her sons. Another application for this is a patient with multi-level prostate CA with multi-level metastatic lesions, severe compression of the codaquina here and the conus. He couldn't move his left leg at all, was 0/5. On the right side was 3/5. And again, this is difficult. What are you gonna do? Multi-level corpectomy, then posteriorly where you stop, and then everywhere you stop, it's gonna break above or below. And that's the problem, you know, with those. And probably Omar has seen and done some of those with me. And what we did is infix. And we published that also, presented at the Academy last year as well. So we did, this is a patient here. And you can see that once you stretch that spine and stabilize that spine, neurologically, the patient will recover. Even without corpectomy, you remember that, you know, how much cord compression, simply because what happened when the patient sits up, it's like sponge, it squeezes the spine canal. And then when you extend and then stabilize them, that will keep the nerves happy. So the cost of the journey, and of course, you know, I have my own share of misplaced screws, you know, screws being in the canal or screws pulling out. You know, I had to do my own revisions on these cases. We publish our complications as well. You know, maybe Dr. Abdul-Jabbar can share those with you. And this is, you know, my early on experience as well, loss of fixation. And this is proximal failure. You know, this is patient we did. We'd stop at T10, and then later on it pulled out, and we have to extend proximally and put some cement as well. And this is a patient here after revision surgery. This patient came to me with this picture. I did the this fixation, and this is inadequate correction. And this patient came to me with the Harrington fixation, significant loss of sagittal balance. I thought I could manage that MIS. Of course, I did that, and it was not enough. So these are part of the complications that happen. They're going to happen with you when your practice grows and mature, and you learn your ways how to do hopefully better and better jobs, you know, with time goes by. This patient here, suboptimal correction in the coronal and the sagittal balance. So, so for the first intuition that, you know, people say, what's my goal? I want to be able to do T1 to S1 or something. No, what I learned over the last 15 years that MIS surgery allows you, particularly if you, we'll go back to the slide where the 3 levels plus a concept that I have, it allows you to manage the soft tissue of the disc very efficiently. I treat every spine as a soft tissue, not a bony structure, because if you do enough release, you do correction, this, you know, all the goals, you can meet them with the least amount of complications. So my goal was to go, I thought was go from, you know, from small incision to do this. Actually, I found out that is to take a disc, you know, experience like this and make it like that. Basically, treat one disc at a time, treat the soft tissue carefully, treat the bone carefully, get the sagittal balance correction. And this is a patient with severe osteoporosis on the right. We did cement augmentation from the front and the cages and the screws on the front, and we did not have to revise that. And I want to thank you all for taking the time. And too bad we missed you this year in Beirut. We will miss you, but for sure we will catch up at the later date. I'll take your questions.
Thank you, Dr. Tony. Great presentation. Thank you very much for your time. Actually, we have a good.
Thank you, Tony. Thank you very much.
Thank you.
We have a good number of questions, so kindly bear with us.
Absolutely.
First question about, do you routinely remove the implant after fracture fixation?
Do I? Yes, I do. Initially, yes, I did. And then later on, I start telling my patients, because I noticed that we do a lot of patients with a trauma, MBAs, and that they're not necessarily close by. So they come from far and near. And so I noticed that when you do thoracic spine, some patients don't want to come back to you, and they say, you know, doctor, I'm doing fine, and I don't want to, you know, I don't need to take them out. I don't have any discomfort. So what I noticed that the thoracic spine, you don't not need to take them out unless if the screws start getting loose or the rods is going to start, you know, a break or something. And that means there's still enough motion in that thoracic spine. But, you know, more often than not, actually, because this thoracic spine is stiff, and the body also creates a little bit of halo of bone around the rod and the screws. And you don't need to take the thoracic screws out.
So the next question is how to minimize the iatrogenic facet injury through MIS technique. If you have any tricks for this, or?
Yeah, I mean, as Dr. Bacco and I were talking before the start, the problem with open surgery is really you cannot start your point laterally enough. And then the soft tissue and the muscles force you to start at some point, and then you cannot aim in enough, so that way your screws end up being lateral. So and then violate the facets. So the MIS, you know, you don't have to take that difficulty. Basically, you can start your incision way too lateral. I tell my residents and my fellows, and then Omar probably remembers that, you can never be too lateral with your incision. So you can always move your needle in, or you're all in, but you cannot try to push it out laterally. So in other words, the best way to preserve the facets is to make your incision more lateral than you think, but also your first landing of whatever you use, a jam shearing needle or all, whatever you need that use, you got to take a shot on the x-ray, and you got to make sure that you're on the TP, which is not, you should at least find 2 millimeters of room between the tip of the needle and the pedicle. That means you are on the TP, because if the needle is right at the edge of that oval shape, the eye of the owl, you could be on the top of the facet, or you could be a good entry point, and you don't know between the two of them. So if your instruments, whether being jam sheared or what, it's about 2 millimeters or 3 millimeters lateral, and you see a clear distance between the tip and the eye of the owl, which is the pedicle, that you know this is TP. Now I glided more medially until I get that wall, which is the facet, and that's the best way to preserve the end plate.
Okay, we got these questions early in the presentation. I think you answered it well regarding the what's your trick to how to restore the sagittal balance in the deformity with the MIS.
Yeah, I cannot stress on this enough. I mean, I go always on the concave side. You have to detether the spine because the tether is anteriorly and on the concave side. So I have to go always, and I release that. And you have to be extremely, extremely, extremely careful with the soft tissue. I keep, you know, like if you were to come and observe, and or when I go, you know, we used to do some cases, you see me spending 95% of my time on the soft tissue, and only 5% on the instruments and cage placing or the bony components, and for a reason. So the only way you could get a good enough sagittal balance is by doing enough release and preserve the end plates. We're doing really, really exciting study right now, and also would like to actually, we can talk off meeting about a couple of studies we're doing. We would like to collaborate with you on this one. We're doing a analysis of the end plate violations, and we're building a classification on that based on measurement of the how much end plate violation by direct observation. So that's a very, very exciting project that, you know, we're finishing now. Actually, we already submitted. But we can follow up with Dr. Bacco and Omar and the rest of the team, people interested to join the study on that.
Okay, the next question is about the CT angio. Do you use it routinely for your L5S1 lateral ATP, or you depends on the MRI?
I never use CT angio for that. I only use MRIs. CTs is when patients cannot have MRI. But I do the again. Also, we are publishing now. Actually, it's been submitted about the anatomy of the vessels and how much the working corridor between the vessels and the psoas. And we have always found that you can find enough room to work next to the vessel, so we don't need to do that.
So, and actually a nice concept about the missing levels, and we have two questions. So do you
Yes.
need to put cross connectors, or
No, because I mean the whole idea is you remember that the large footprint cages that we use in ATP and trans-psoas, usually the large footprint cages, these are large enough that the rod posteriorly is really neutralization force. It is not doing much. It's a tension band. So you don't need a lot of rigid fixation in the back. So most of the load is being, done by the cages support. So the answer is no. And also it's gonna counter argument the why you want to do MIS and try to put cross connected and so on. It's truly not worth it, and you're creating more muscle damage than you think.
So, and about like the same concept that the skip levels, how much do you think enough implant and for certain number of levels, let's say T10 to pelvis or L2 to pelvis, to maintain the correction what you get?
Yeah, so 99% of our cases, let's say I could give you example, real examples. So if I'm doing L4 to S1, I'll do only L4 and S1 and put the cage in the front. So almost 99.9% of our patients. If I'm doing L3 to S1, I will do L3, L5, and S1 screws. If I'm doing L2 to S1, I'll do L2, L4, S1. And this scenario is in 99% of our cases. And if I'm doing T2 thoracic to the pelvis, and these are the examples you saw them, and I do T12, T10, T12, L2, L4, S1, and the pelvis. So I try to skip every other level. And for the reason I mentioned before, because I do have the interior column support by the cages.
So, and in one photo, you showed that you able to reach posteriorly through the anterior approach, like with
Absolutely.
the yes.
Absolutely.
And one is asking how you can do the decompression through this like direct decompression.
Yeah, because you are coming at an angle, and then like yesterday, I did a patient who had severe stenosis, complete cutoff. The patient couldn't get MRI, but they get the CT myogram, complete cutoff at L3-4, L4-5. The entire canal was filled with disc ossified complex. So I go from the front, I make my incision slightly more anteriorly, and take the disc out. You're looking at the posterior annulus. You take it down, you take the carotids, you take the ossified, just like doing ACDF. Same way you do foraminotomy for ACDF. It's exactly the same technique. And it's truly easier than you think because you're looking at it as well. But you need to be little by little, try to develop your skills with that, little by little.
So, and can you tell me more about your technique, how to release the AL?
Yeah, right. So, basically it's very simple. It's a low tech, what I said before, it's, what's really the cost of what you're doing? If it's too complicated, it's not going to be worth it. Basically, it's easy. I put my retractor in front of these ALL, and I take my big knife and then split it in half. It's a very safe, very reliable, and very predictable because you can do it in every case. So I put my retractor blade in front of the ALL and cut it with a knife.
Okay. So regarding the derotation and about like you show some cases that you are doing anterior interbody, then you are doing the derotation. So any movement in the interbody, or is this like easy to do the derotation after you put the interbody?
So it's extremely easy. I'll tell you why, because it's easier than you think, because by the time, and I wanted to comment last week, 2 weeks ago, when Harry Scheffelberger was on the call.
Mm-hmm.
And when I asked him, one time I was struggling to do I have idiopathic scoliosis at type 6, and then and I was having a hard time derotate the distal part of the scoliosis, because it does kind of turn the adjacent segment, the below instrumented segment, into more rotation. So I called him up. I told, hey, Harry, you know, how do you do the derotation? He said, well, the way he explained to you, he said, I fix on the convex side, and then I distract
Mm-hmm.
on the level below and compress on the convex side. And I said, wait a second, that's what I do with MIS every time. And that's why I'm getting derotation every time. So by doing the cage in the front, you're unlocking the facet. And if you look at the CT scan of the vertebrae, you find that the CT scan, the vertebrae are not perfectly flat, they are wedged.
Mm-hmm.
So for that vertebra to derotate and then to allow the vertebra to derotate, you need to unlock the facet. By putting the cage in the front, you already unlock the facet. So that's why the derotation is much easier than you think. That's why I said it's much easier. If you look at those, you know,
it's like a segmental derotation, not like a in block derotation.
Yeah, like if I'll show you, you know, this case, like I'll give it, like take this case, right? Do you see the screen?
Yeah.
Yeah, I challenge any open surgery to do as much of derotation, and look at the spine's process in the middle. It's perfectly in the middle. And this is not like a one case that we chose. It's basically, you could take another case like this, and then you look how much rotation there is, and look how much derotation there is.
Mm-hmm.
And guess what? Comes with really, by the time you're done the front, and you go posteriorly, and you know, when you put the screws, and the spine will derotate by itself, because you already unlocked the facet from the front, and you already opened the space in the front. So it's a lot easier than you think when you get the second stage.
Nice. So the last question is actually about the one stage ATP. Did you try one stage, like to put the screws in the same position lateral, or?
It's not worth it. I mean, trust me, I've done it 15 years ago when we first developed the Viper, and if 8 out of 10 times it goes, the problem with that is the C-arm doesn't turn all the way under, so it becomes technical issue with the C-arm, because it doesn't go from AP to lateral all the way. So you have to rotate the C-arm in a different way to go over the patient, not under the patient. That's number one. Two, you're working off angle, you know, and if you drop any instrument, it's going to fall on the floor, because you basically try to fit yourself between the C-arm and the patient. Mm-hmm. It's not worth it. It's posteriorly, when you flip the patient, it literally take you, what, 20, 30 minutes to drop 4 screws, whether L4 to S1 or L4 to L5. And you're working on top of the patient, you know your dimensions, you know your orientation, you know the horizontal and the vertical planes. It's just easier and safer. When I do from the side, sometimes when the patient's coming to me with already hardware, and I need, instead of me doing posterior, anterior, and the posterior, I release the screws in the back through 1 centimeter incision, as you saw on the couple of sample cases, and that's worth it, you know, because I'm not putting hardware in, I'm not aiming, I'm not taking AP and then lateral and all these things. It's to me, it's simpler, easier to do it that way.
Okay, is there any other questions for Dr. Tannoury? Kindly go ahead and unmute yourself and ask.
Thank you very much, Dr. Tannoury. I'm Dr. Saeed from Doha. I noticed that you put cages anteriorly and you do excellent derotation after putting your posterior implant. How do you ensure that despite your ALL being transected and completely free, that your cages do not move or spit out or displace?
Yeah, that's a good question. I'm asked this question almost every time, and I do on average about 900 cases, 900 cages per year, and I've been doing this for 15 years, 14, 15 years. I never had one cage kicking out, and then the only time I had the cage kicked out when the vertebral body itself fractured, and it fractured because it was a wedge. There was severe scoliosis, and there was only wedge vertebra, so the vertebra was already like a triangle, and so on. And the reason is that I wanted to think, of the disc as the uterus of a woman. Now, the whoop stresses are such that when you have axial loading, the load goes down. The whoop stress is transferred axial load into horizontal load, and which is axial load, and then radial load, and that kicks the cage out, goes out. So the only way you can transition from axial load into horizontal direction is if you have a soft tissue. If you have two pieces of bone, take two pieces of wood now and put a small block between them. And even if you have half of the block, if you look at actually some of the cages, I have third of the cage, it's even not in, even slightly uncovered. And I'm okay with that because there's nothing to push it out. So what's gonna push the cage out is the remaining soft tissue. Now you can take two pieces of bone, a dry surface, which is dry end plate, after you clean the soft tissue out nicely, and then you can rotate those, and the cage truly it doesn't split. So I never, if you look at all these cages where the triangles look like the disc is triangular, you would think, oh my God, what's going to happen to the cage? They don't go anywhere; they stay in place. You can try that, and I guarantee you that is you're never going to have a cage coming out. Now, the only time the cage will go out, if you do middle third discectomy, you leave a lot of disc around and the back end of the cage. So when the patient stand up, the axial loads become whoop stresses and more radially oriented loads, and it's gonna the cage is gonna come out like a bullet. That's why if you look at XLIF forums, if you go and look at surgeons who have different shared cases and so on, you see that very commonly, with the cages going into the psoas again. Why? Because I did not do enough discectomy.
Thank you very much. Excellent, excellent. Thank you. Very kind of you.
Okay. Is there any other question? I think there is another question actually by Dr. Mansha about the complication rate in your hand about MIS adult deformity.
So I would refer you to our published results. We have the world's largest series on this. And now we have 1,860 some cases. And the neurological complication 0.4% on those being having like a drop foot or any weakness, new weakness in the leg. And the majority of those are patients who had the prior laminectomies.
Mm-hmm.
Because when you have prior laminectomy, the nerve is stuck and with adhesions, and when you try to derotate and correct the spinal alignment and lengthening, whatever, you're lengthening the spine, and that may stretch that nerve. So revision of hardware is 0.4% again. Iliac fixation, actually, we are publishing that. We already submitted to a spine journal. It's about 2.5%, having patient going back in for removal of hardware of the iliac or painful hardware of the iliac. In open surgery, like if you take a look at Larry Linke series, they talk anywhere from 8% to 30% of need for removal of the iliac fixation. We talked about misplaced hardware, like needing to be removed is less than 1%. I would say if you ask the patients, do you have any thigh pain? Do you have any symptomatic sympathectomy type syndrome symptoms? A lot of patients would have that, but they have it for a short period of time. I ask every patient if they have anterior thigh pain or burning, and they tell me, I had a little bit of that, and the way you told me is going to go away, it's going away. So for the patients who do have it and then keep it for more than a year, I think we have about 3 or 4 patients who have a long-term anterior thigh burning and pain. Vascular bleeding, we have a 0 so far, thank God. We have about 3 patients who when we retracting and spreading this and so on, we ripped the segmental, not the main vessel, the segmental, and the segmental ripped off the origin of the common iliac. So, and it's, if you look at the anatomy, when you look at it next time, it's away from you, so you cannot see the origin of that segmental where it comes off these common iliac. So every time I try to turn the vessel to repair it, and then you see blood, you cannot see the hole because now cover your hole, you cover your vision. But when you let go, it stopped by itself. So I learned that trick in my first case when I had that segmental bleed and I couldn't, so I put gel foam and left it and nothing happened. So it happened a couple more times after that when you have a segmental ripping, and you will see that the remaining of the segmental kind of retract inside the main vessel. Inside, it comes like sleeve, like a rubber sleeve goes inside the main vessel. And then the best way, just let it go. Because the vessel, the segmental comes off at about, if you think of the vessels about the clock, 12, 6, it's about 8 or 7 p.m. So when you let go, that 7, 8 p.m. is butting against the spine. If you put the gel foam there, it will stop that bleeding by itself.
Okay. I think this is the end. We really enjoy your talk, Dr. Tannoury, and one of the great presentation. Thank you very much.
Oh, my pleasure.
Yeah, thank you for your attendance. So next talk will be by Dr. Jad Khalil. It will be at the end of the month, actually. The date will be announced later. He will speak about navigation and robotic spine surgery. It's a nice and interesting talk.
Yeah, send me some reminder. I love Jad. Jad is a very, very good surgeon. He's very upcoming spine surgeon here in the in the community.
Yeah, sure, Dr. Tony. And
thank you very much, Tony.
Thank you, Habibi. Thank you. And then I will be communicating with you soon about those couple of studies we're doing. I would love you to be part of it.
Inshallah.
Inshallah. Thank you.
Thank you, Tony. Thank you. Nice to hear from you.